All right, so next we're going to be talking about peripheral artery disease. So first thing we need to start looking at with peripheral artery disease, review the patho. So what we're talking about here is obstruction of the arteries that supply the distal extremities. So symptoms are mostly going to be seen in the legs. Sometimes occasionally patients can have symptoms in the arms, but not nearly as common as lower extremity symptoms. Main reason for this, atherosclerosis, narrowing of the arteries. So preventing blood flow from reaching the distal ends of the extremities is a big one. And some of our big risk factors are smoking and poor care of chronic diseases such as diabetes. So when we're doing our assessment on these patients for recognizing cues, the big body systems involved here are our vascular system, because we're not getting enough blood flow through it, and our skin. So we're looking at, if we're not getting enough blood flow through the vessels, we're also not perfusing the skin and interstitial spaces where that obstruction is occurring. So skin is where we're going to start to see a lot of our symptoms as well. And then we always want to identify for chronic diseases any risk factors that could be accelerating the progression of a disease. So we want to look for smoking in patients and counsel about smoking cessation because it is going to make their disease worse. And also like untreated heart disease is another big one because that's going to contribute to more of the plaque buildup in their arteries and more hardening of the arterial walls, which can lead to an exacerbation or kind of not an exacerbation because PAD doesn't really exacerbate like CHF does or things like that, but it'll just progress. So it'll just get worse. Some of the specific cues we're looking for. So because this is an arterial disease, we're looking for alterations in the pedal pulses or the distal pulses. So they can be diminished or they can be absent. Patients will also have an altered cap refill when we do our little skin checks on them. So it's going to be very, very slow to refill, and it may not blanch very much when we squeeze it because there's very, very poor distal arterial blood supply to the feet and to the distal ends of the hands. These are patients who are also going to have very tight looking skin. It's almost like their lower leg, like between their knee and their ankle, like their calf area has been shrink wrapped. And it's going to be kind of disproportionately smaller and tighter looking than the upper part of their leg. They're going to have alterations in their hair patterns. So because there's so poor little circulation getting to like the hair follicles, they're going to have very like thin or kind of patchy hair distribution. And very, very characteristic are these punch wounds for a peripheral artery disease. And I'll show you a picture of those in a little bit, but what the punch wounds look like is almost like somebody took a hole punch and punched a hole straight into somebody's foot or ankle. Usually they're at the very distal ends of the extremities. So the feet and ankles are really prevalent areas for us to see these. These patients are also going to be having intermittent claudication. So similar to we see for kind of cardiac chest pain with exertion kind of stuff, these patients are going to have an increase in pain to their legs when they're up and moving around and have greater oxygen demand for those tissues. So we do see that kind of a pain pattern very commonly with peripheral artery disease because of the poor kind of distribution of pain. Sorry, my phone just rang. For prioritizing hypotheses on the medical side, a big part of this is physical exam. So looking for their pedal pulses, appreciating or kind of palpating that they're diminished or absent, and may require a Doppler in order to hear their pedal pulses if we need to. A Doppler is like an audio kind of, it's like a very sensitive microphone that we can put over a pulse and we can hear the heartbeat through or hear the pulse rather than feel it with our fingers. So what you'll hear when you use this device is something like a boom, 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 boom. It's almost like listening to somebody's heartbeat. Another screening tool we can do is called ABI or ankle brachial index. This is like checking blood pressures on patients' legs. We check the left and the right and compare those values to come up with one numerical value that we can use as diagnostic for peripheral artery disease. But again, physicians or subspecialty nurses like wound care nurses are going to be doing that exam. For imaging, angiography can be done. So we can see some pictures of some distal angiography here on the left part of the slide, where there's been dye injected into the arterial blood flow, which helps us to see it on X-ray. If you look at image A, we can very clearly see that this patient has very, very poor arterial blood flow where that branch of the artery just kind of stops. So that would be very indicative of advanced peripheral artery disease. On the nursing side, some of the diagnoses we use are ineffective peripheral tissue perfusion, activity intolerance. So the tissue perfusion is talking about the kind of trajectory of the disease and like what it actually is. You know, we're not getting blood flow to the distal extremities. The activity intolerance is really speaking towards that intermittent claudication kind of symptom that patients have. So for risk management, these patients are at very, very high risk for injury. When we block blood flow to the distal part of the body, some of the things that go along with that are numbness and changes in sensation. So these patients are at very high risk for injuring themselves and perhaps not feeling it because they have decreased nerve sensation in the distal part of their legs. So very, very high risk. The other thing that places them at very high risk is they don't have adequate tissue perfusion to their distal extremities, like to their feet. So if they do get a cut or an injury on their feet, it's very, very high risk for becoming infected and remaining an open wound for a very long time because there's not enough blood flow to that wound in order to help it heal at normal progress that a patient should heal if they have adequate blood supply. So those are some of our big risk management things we need to think about with peripheral artery disease. For generating solutions on the medical side, the main goal is returning circulation. It's the problem, and that's the solution they're looking for. On the medicine, and usually that's a surgical solution, is returning circulation. So they'll do procedures like stenting, where they're going to insert a stent into the artery, inflate that stent to help keep the artery open and return blood flow past the area of constriction. On the medical side, we're looking to kind of manage, we can't really address the blood flow problem on the medical side, but we want to address the symptoms of the disease. So pain management is a big one, especially neuropathic pain associated with poor distal circulation and nerve damage because of that long term, and the wound care. These patients are going to have prolonged wound healing. Like we're talking, they can have an open wound for months or years because there's such poor circulation reaching that wound bed. There's going to be very, very poor tissue regeneration and wound closure happening. So physicians are going to be involved with the wound care of these patients over a long period of time. On the nursing side, we want to promote independence. This means ADL support because these patients are going to have a hard time walking around because of that intermittent claudication pain that they experience in their legs, and also because of the impaired sensation. So we always want to plan for frequent rest when they're performing their ADLs. So these are things like putting a chair nearby so they can sit down instead of rather than standing up like at a sink to wash their hands, and also addressing their pain. Because we do know that intermittent claudication pain means their pain will get worse with activity, but it can improve or subside if they rest a little bit while they're being active. So that's one of the big ways that we can support patients, is that through that rest. Then we want to prevent harm. So wound care is a big thing that we do for peripheral artery disease patients if they have peripheral artery wounds. These are specialist wounds because they take so long to heal. This isn't the kind of wound where we can like put a Band-Aid on it, or even a wet to dry dressing isn't a great dressing option for these types of wounds. It can actually make them a lot worse. So we want to call in the wound care nurses to give us some of the specialty products like silver gels that can be placed inside of wounds that can help facilitate wound closure and wound healing. And if they have wounds, we always want to be on the lookout for infection signs and symptoms. So redness, erythema, edema, pain around those punch wounds is really suspicious for edema. So, for infection. So we do want to look out for those things. When we look at taking action, so a big part of the management of peripheral artery disease on our end as nurses is assessment. So we're going to be doing CMS checks on them, and CMS stands for circulation, motion, and sensation. So we want to check their pedal pulses for circulation. We want to see if they can move their foot, so dorsiflex, plantarflex their foot independently, and sensation, so can they feel us touching the distal parts of their extremities, or can they only feel us kind of up on their calf if we're touching their leg? So those are big things we want to check routinely. And then we need to check their foot for wounds, especially their lower extremities. Because of that neuro impairment, they may not know if they develop wounds or not. And a lot of patients can develop foot wounds from peripheral artery disease just if like their shoes are on too tight. So if for normal people with not for normal people, but for people with normal circulation, we can feel when our shoes don't fit right, when they're a little bit tight. For patients with peripheral artery disease, they may or may not be able to feel if their shoes are too tight, and they may be at very, very high risk for, instead of just be feeling uncomfortable, they'll develop a wound from that pressure from their footwear. So that's always something we need to check with these patients. These are patients where we need to take their shoes and socks off and visualize their foot and look for wounds. Here's a picture of what one of the peripheral artery disease wounds looks like, that punch wound. So you can see that it's a really well-defined circle that's kind of punched into the skin. And that's that punch wound type of appearance. Then for activity, we actually want to promote activity in these patients. And we're not talking about like vigorous activity. These patients should not be like getting on a bicycle and going riding up the mountains or running around City Park, things like that. These are patients that should do moderate, like very light to moderate exercise. So they should be getting up and walking around. And the reason we want to do that is actually to promote circulation for these patients, because what will happen is the artery that's blocked is going to remain blocked. But with activity, it's going to reinforce some of those secondary arterial pathways to help get a little bit more perfusion around the blockage to the tissues downstream of where the main artery is blocked. So we can really improve those secondary circulation pathways. So gentle exercise is really what we want to go for here, but also counsel patients about the pain and the intermittent claudication symptoms they may have. So they may need to build in periods of rest while they're doing those gentle exercise programs. For diet, we do want to teach these patients to be on a cardiac diet, so low fat, low cholesterol, because we do want to limit the rate at which those plaques are building up in their arterial system so that they don't continue to have a worsening of their distal circulation, because the plaques are just getting larger and impeding more blood flow to their extremities. And then for education, we want to teach our patients all this stuff, how to check their feet for CMS checks and wounds, how to start ambulating so that they can promote circulation, and about diet teaching so that they can prevent the progression of that atherosclerotic kind of manifestation of the disease. On the evaluation side, we want to see progress kind of on all fronts. So for the assessment, kind of our objective data, we want to look for return of circulation or maintenance of circulation. And we'll do that through our pedal pulse checks. So that's a big thing we want to be looking for. We want to maintain their baseline, or if they've had a surgical intervention, we want their baseline to improve. We want to have a stronger pedal pulse if they've had a surgical intervention. For activity, we want them to be able to complete their ADLs independently, or as independently as possible. So have a plan for preventing claudication, building in those periods of rest while they're completing their ADLs. And then the activity programs. We want to help guide them as to what is an appropriate level of activity and what to do should they experience some of that intermittent claudication when they're doing their activity programs. And then for patient education, self-assessment, how to check their skin and make sure they're staying safe, how to check their pulses, how to check for wounds, how to check for nerve damage, so the sensation, and also their diet modification is another big thing we want them to be able to, we want to assess that they understand so they can help to manage their disease independently. So the super important stuff, recognition of symptoms, looking for that tight skin, poor pulses, and those punch wounds, because that's going to guide therapy goals. It's also going to guide our teaching. So we do want to identify exactly what symptoms are going on because we're going to adjust our teaching based on that. If patients don't have wounds, there's no need to do the wound care piece. If they don't have intermittent claudication, we can push for a little bit more of an activity program. Whereas if they do have those things, we do need to be teaching them those particular topics. And then recognition of risk factors, and especially the things that are going to progress their disease. So high cholesterol diets are going to help to accelerate the progression of their disease. So really teaching them about that, and also about their wounds. They need to be taught to check their feet. It's a big, big thing. Key assessment findings. So we talked about those altered pulse, which can be diminished or absent. And we may need some of our specialty equipment in order to accurately assess their distal pulses. So those Doppler machines might be essential for patients with severe peripheral artery disease. We talked quite a bit about the intermittent claudication. So we want to keep our patients as comfortable as possible. So building in those periods of rest so that they can be as independent as possible. It's just going to take them a little longer to complete it because they need to have those periods of rest in between being active. And then wounds. So we're going to be looking for those punch wounds because that's going to be a big indicator that these patients have developed intermittent claudication. And don't forget to teach about how this disease works. It is a chronic progressive disease, meaning they're going to be living with it for a long time, and it's only going to get worse. So how to slow down the rate that this disease is progressing is a big, big thing. We want to slow the progress and manage the symptoms of this disease. We don't have a great cure for it. So living with it, living with the symptoms is much more in line with our treatment goals.